So good afternoon to all of you. So the idea is just to give you a brief update on the Trabecular Bone Score in terms of clinics as a quick outcome, but also mostly talking on the reimbursement in the United States with a CPT code level 1, which has be a game changer for TBS and really for the clinical outcome for the patient, which is very important. So I will introduce later on Dr. Lauren Nicolas, the CEO of Triad Radiology, but also been working quite extensively with ACR down the road and been also a specialist of reimbursement, as you can imagine. So I'm Professor Didier Hans. I'm co-managing the Center of Bone Disease in Lausanne University Hospital. I'm happy to say that this hospital been in the top 10 according to Newsweek magazine just 2 years ago, so quite nice for us, good advertisement for us. But also the founder of TBS and Medimaps, so just for you to know my conflict of interest, even though I will really stay on the clinical side for today. So osteoporosis, a few facts. We talk about osteoporosis is a silent disease, so we tend to forget about it. However, we have one fracture every 3 seconds in the world. So it's huge. Between all talk, it will be a lot. And we have 1 woman out of 2 in the US over the age of 50 will break a bone. So it's quite substantial. Even though we don't pay much attention about it, there is really a public health issue. And unfortunately, the cost also associated to that, either to fix the fracture or comorbidity or whatever is quite used for the society, where it costs us roughly about 124 billion per year worldwide, which is also a significant cost. The good news is osteoporosis can be partly prevented or treated, where treatment can reduce 40 to 70% of the fracture, depending on the type of fracture, and also improve the quality of life for the patients. Yet, from fracture, you can also die. You have 20 to 40% of people been dying within a year after the fracture in the elderly people. So that's quite substantial. Another point which is interesting, although we have a lot of fracture every 3 seconds, is really 1 woman out of 2, you still have about 70% of the patient at very high risk that never been screened, not even diagnosed, and then be just left in nature until they get the fracture, and sometimes not even treated for osteoporosis, just fix the fracture. So having said that, let's say go to osteoporosis definition. What is osteoporosis in fact? Osteoporosis is a skeletal disease characterized by 2 things mostly. A low bone mass, that we know that the density of the bone, but also microarchitectural deterioration of the bone leading to an unacceptable level of risk or the fracture itself. So we all know about the density because that's the gold standard, and we tend to forget that the basic definition of osteoporosis relies on those 2 pillars, density and structure, and that both are important. So because of that, because we rely the definition of osteoporosis on both, but we do in clinical routine mostly the density, we miss 40 to 50% of major fracture occurring in a non-osteoporotic zone. As you can see on these following slides, we see that when you decrease the density, you increase your level of risk. But if you count effectively the number of fracture, you will see the majority of the fracture will be really in a non-osteoporotic zone. Why that? Because you can have a same patient with the same density, but the underlying structure can be quite different. As a mechanical strength, one will be more fragile than the others. So with the same density, one patient can fracture, why not the others? So having said that, if you move to the TBS, TBS stands for Trabecular Bone Score. It's been FDA approved in 2012 already, another clearance in 2015, so been well established. As of today, there is more than 1,500 peer-reviewed publication, more than 30 guidelines around the world, been reimbursed in the United States already for 1.5 years now, and is really becoming part of the clinical routine just to really have a better idea of the patient bone status. So you can have exactly the same density from 2 different patients, then the underlying structure can be different. We use an experimental diagram being pre-optimized by artificial intelligence, but at the end, we use an experimental diagram which we use in geophysics by the NASA, some other agency, just to analyze the soil from satellite image. So the X-ray is a bit like a satellite looking at Earth is a radiologic looking at an X-ray. So the distance is about the same, and we can have some tools that extract some microstructural information from 2D image. So what we have, when we have a high TBS value, it correlates to a good bone structure, where you have a low TBS value is correlated to bone microarchitecture based on cadaver study, micro-CT, and some other studies. So from a integration standpoint, I know that a lot of things takes time, and when we add, as a clinician, we add more things. We don't like that because we need to do more in less time all the time. So the TBS is totally integrated into the workflow, meaning you don't have to do anything except do your DEXA scan, analyze your DEXA scan, and within a few seconds, you will have a full report that reporting the BMD, the TBS, and more. So we'll come back on the full report. So really post-processing in 10 seconds. You can also reanalyze the path if needed. So as a clinical evidence, one thing I told you before, that a lot of fracture occur in a non-osteoporotic zone. If you hear, this is the first study in 2011 where we go to the FDA with that one, from 33,000 women from a prospective cohort in Canada. What you can see here from the minimum BMD T-score, you can also have the lower TBS here from a high to lower T-score. Obviously, you have a good normal bone in terms of density and structure. The level of risk is extremely low. Reversely, if you have osteopenic patient and degraded structure, the risk of fracture is extremely high. But the interesting one, so that potentially we candidate for high-risk drugs like anabolic Evenity, or whatever, so those drugs, like anabolic drugs. Now here it's quite interesting to see if you're osteopenic patients, but with a degraded structure, your level of risk of having a fracture is pretty much similar to someone which is osteoporotic on a sole basis of density. And that's where we're recapturing part of the patients. So having said that, this is a workflow that we use in Osteo, and that's been also incorporated into the latest guideline from IOFHO under the auspice of WHO. So what we have, I will not go through all of this. We can refer to the publications. I will really focus on not the image acquisition and so on, but really the DEXA owner radiologist, but also for the referring physician in 2 minutes. So what we have here, the first thing is, besides checking the quality of the image, because we already have the same thing, garbage in, garbage out. So if you do a bad DEXA image, you will have a bad outcome. That's why we teach at the ICD courses. But what you need to know here is, first we'll try to estimate the density from the BMD T-score, the DEXA scans, but we also have the TBS classification as a normal, partially degraded, and degraded. So you will combine both to create what we call the bone fragility index. It's like a mapping based on the density in one side and the TBS as the microstructure of the other side, and then the level of risk associated, as you've seen in the 3D before. So it is quite interesting for several things. First of all, you will start to identify the very high risk zone or high risk zone, and on that person, whether or not you want to treat the patient, you will just focus on two things. Either the BMD T-score adjusted by TBS or BMD, the minimum of BMD T-score or BMD T-score adjusted by TBS, or the FRAX adjusted by TBS, which is also integrated in the FRAX as of today, depending on the guidelines of your countries. When you have both of them, then you can define whether or not you will treat the patient or not. How to treat, the way we use that is not a FDA claim, so to speak, but what we start to think as a clinician is a mapping of the level of risk. Obviously, if you have a patient which is osteopenic and a high level of risk and a degraded structure, you would like to treat with a drug that will impact both the density and the structure of the bone. So luckily, to some extent, all drugs are increasing the density, but not all of them are increasing the microstructure of the bone. So you start to map your mind, where saying, depending on the level of risk of the patient, where he's standing in terms of density and structure, to start to select the type of treatment will most likely be the most appropriate for the patient for a given type of profile of risk. So finally, How long should I treat? It's always a tricky issue with the patient. They want to get out as soon as possible. So the idea here is to treat to lower fracture risk zone and try to embark the patient in the decision you're going to make at one point. You can have the patient, well, you don't want to have, for example, denosumab, you want to have a biphosphonate. Okay, you in this zone, if you want a biphosphonate, I will have to treat you much longer to get you out of the high-risk zone because you will not improve the structure, but I will have to treat longer. It's okay. However, if you have a more powerful drug, you can go faster out of it. So, just to summarize the whole things, everything that I say is fully integrated into fully automatic report where you can find the structure, the BMDT score adjusted, the FRAC, everything is comparable, and you have a fully automatic conclusion which just takes the DEXA element and the TBS element, so you have more clinical value and also gain of time on the DEXA report by itself, and it's a structured report that can be imported in everything you want. So having taken that, the WHO, IOFHO under the WHO get the latest guidelines, and I'm sure you have some of these guidelines somewhere on the table, and people will be able to do that. I will not go into the detail, but they really push for primary, secondary, and patient response to therapy according to the type of drugs. So I will not talk any longer. I can talk for hours. But yeah, do you have a question?
We do these types of exams frequently, and I've noticed that most of the patients that we get from the cohort that's sent to us have low trabecular scores, even if they have normal or mildly osteopenic status. That's most of them. Is it an age-based issue similar to what we see with bone mineral density, or some other issues at play?
Well, I don't know the type of population you have, but in order for the TBS to have added value to the BMD, you need to be independent, okay? So the BMD add a different type of information, really the density, where the TBS is independent and will provide you information which is quite unrelated to the density itself. If you go, for example, to population with secondary cause of osteoporosis, most of the time the density can be impacted somehow, but not as much as the microstructure. If you take, for example, glucocorticoid, the density will be slightly lower, but in patient, the structure will be more impacted the density. If you have another problem is the elderly population, osteophyte will tend to increase artificially the density, whereas the TBS is not impacted by osteophyte. So in that case, it will give you a better information about the structure, which been a bit overlaid by the density because the artifact of osteophyte. That's some of the reason. Now, it depends about the population, but then I suggest we can further discuss that after this little workshop.
So we heard about the clinical utility of Trabecular Bone Score. I'm going to talk a little bit about how your practice can get reimbursed for it. Certainly it's good to provide best patient care. Doctors are altruistic. We're going to do it regardless, but it's also nice to have a financial return and a good business case for this. Okay, so most people apologize for their busy slides. This slide is busy on purpose. This is the gear system that is the monstrosity of the U.S. healthcare reimbursement system. We start here at the CPT system where a code is created for a healthcare service. It goes to a body called the RUC, which puts a valuation on that CPT code. That goes to Medicare, who makes a decision on whether they believe what the RUC recommended. That gets filtered into payment rules, whether it's the physician fee schedule or the hospital outpatient prospective payment system or the inpatient system. And then that eventually percolates into payment structures for both physicians and hospitals. So this is a really complex, crazy mess. It's hard to navigate. It's hard to know what's going on. So we're going to talk a little bit about how the code for Trabecular Bone Score fits in here and how you guys can bill it for your practices. Okay, so in the fee-for-service system, obviously value-based care is going to be a little bit different, but in fee-for-service, Medicare has different ways to pay for innovation. Trabecular Bone Score is a great way to better identify patients that are at risk for fracture. It's a new service. Obviously, Medicare should be excited about paying for their for their beneficiaries. So how can they do that? Well, in the physician fee schedule, it's done through the CPT system, through Category 1, Category 2, Category 3 CPT codes. In the hospital outpatient department, there's the HOPPS rule system. There has to be codes and different ways for these all to be reimbursed. Inpatient's a different situation we're not going to talk about. And then, of course, private payers usually piggyback off of Medicare, but we're going to stick to Medicare for this purposes of this talk. Okay, so just because you have a code for a service doesn't mean you have a payment for a service. So we all know that. If you're a radiologist, you have to put something in the indication line that makes sense with why you're ordering it, or you won't get paid for it. So Trabecular Bone Score follows the clinical indications for medical necessity that DEXA does. So they're covered for patients every 24 months or more often as medically necessary in these cases. So I'm not going to read these, but familiar with these. So in addition to having the code, you also have to build the ICD-10 code that goes along with the indication. Okay, so there are 4 specific and separate codes for Trabecular Bone Score. The CPT team, assisted by the American College of Radiology, built these 4 codes purposefully so that TBS could be done in different settings. So the one on the top here is the global code, the 77089. That is if the Trabecular Bone Score calculation is done on the DEXA in your office or in your setting, the radiologist reads it, and that's all billed together as one global code. The 090 is if you do the take the DEXA, but then you send that information off to be processed somewhere else. The 91 is the processing of that information, and then the 92 is just the report. So if you're doing the professional component separately, you would bill the 92. We're going to talk about some examples of these. For 2023 in the physician fee schedule, these are the reimbursement levels for each of these codes. So remember, the 89 is the global, so that's if you're doing the technical component and the professional component. For the TBS, the payment is $41 in the physician fee schedule. So this is if you're a physician who owns your own office, you're billing your technical through the PFS. It's not for hospital outpatient departments. The interpretation alone here is $983. And this is the hospital outpatient payment system. So these are for hospital outpatient departments, whether they're HOPDs or imaging centers that are directly in your hospital that are scanning outpatients. They will not have a professional component. So important to know that the HOPPS fee schedule doesn't pay physicians for anything. So these are only technical component reimbursement structures. So if you're a hospital or a healthcare system or part of a multi-specialty healthcare system, you wouldn't bill 89 or 92 ever. You would bill the 90 or 91. Okay, so the common misconceptions, you led me right into my next slide. So a lot of people are familiar with DEXA. DEXA is billed like most radiology codes, where there's a professional component and a technical component with the same CPT code. And to distinguish those, you use a TC or a 2.6 modifier. The TC for the technical component, the 2.6 for the professional read. You can see that the 80 is the DEXA code. So if you're billing a DEXA, you would bill 7780 with the TC modifier. If you just did the technical part, and the 2.6 if you did the professional part, you would just bill the 80 code if you did it all. So TBS is different than that, and that's important because you don't want denials on your claims. You can bill the DEXA in addition to the TBS. So that's one common misconception, is people think you can do one or the other. You can bill the 80 for the DEXA code plus the TBS. Instead of those TC and 2.6 modifiers, TBS has different codes that specify whether you're using the professional component or the technical component. So if you're doing both of them, you bill the 89. If you're just doing the technical component, you bill either the 91 or the 90. And if you're just doing the read, the interpretation, you would bill the 92. What's the difference between the 90 and the 91? The 90 is uncommon. It's if you had the DEXA equipment, but you didn't have the software to do the TBS, and you were sending that off to another facility that processed the TBS. So usually we don't see that, but that code exists just in case that scenario arises. The 91 is if your DEXA scanner has the TBS software on it and you're doing it all at once. The vast majority of the time it's the 91. Okay, so these are just what the forms look like. I think these are electronic now and not actual paper, but it still looks similar. In the hospital outpatient prospective payment system, you have this UB04 form, and in the physician fee schedule, it looked like this. It's the 1500 form, and I've got a close-up of this guy. So these are 2 different scenarios. The one on the left is if you are a radiology group reading for a hospital, and so you bill your professional stuff, they bill the technical stuff. The TBS exam is done. The facility fee is going to get billed by the healthcare system, the 091, through the HOPPS. You and your radiology practice are going to bill the 9.2 for the interpretation, for the read of it, and that's going to be billed through the physician fee schedule. The second example is if you're a radiology practice that owns your own imaging centers, you own your own equipment, you're doing the TBS on your own DEXA that you own. In those cases, you would bill it all through the physician fee schedule, and you would bill this global 77089 code. This would also be for IDTF, if you're a radiologist who staffs an independent diagnostic testing facility. It's not associated with the hospital. Okay. So again, just to drive this home again, the TBS codes don't replace the DEXA codes. They're additive to those. It's a separate service, even though you don't have to image the patient again, radiate them again. It's done off the DEXA data. It is still a independent code, and they are supplementary. And obviously, the combination of the two procedures increases your reimbursement. Unlike DEXA, which has the 2.6 and the TC modifiers, the TBS codes has different codes for the technical and the professional components. If you accidentally put a modifier on your TBS codes, they might get denied. Don't do it. And then if you're billing to the hospital outpatient prospective payment system, don't use the 8.9 or 9.2 for the professional component because those don't exist in the HOPS. Okay, this is just an example from one of the Medimaps customers of what their coding form looks like here. They've got the medical necessity M810 up there for the ICD-10 code for osteoporosis. First line there is the 77080 for DEXA. The next one is the 77089 for the global code for TBS. And then just to wrap up here, these are the states that we've seen Medicare approve reimbursement pretty much everywhere. I saw some South Carolina folks. You guys are in the white still, but won't be long. So we've had successful customers bill in each of these states, bill successfully through Medicare. That's all I got. Any questions about reimbursement?
It's one thing. I get what you're saying, that that we can better differentiate our patients and see who needs treatment. Is Medicare actually approving more osteoporosis treatment then based on TBS? Because sometimes it is a challenge to get Medicare to approve osteoporosis treatment.
The idea is not to treat more, it's to treat better those who are really in need. And if you have an imperfect tool that can just really say the patient that can be treated, the TBS can also tell you that some of the orthopedic patients that have like a normal structure, then the level of risk is less than if you have a normal low TBS and low structure, the level of risk will be different. So again, it's not a claim. That's the way we use in Osteo, where we will try to identify those really high needs and just differentiate the type of treatment for a given type of profile.
I agree with you. We just sometimes have trouble getting Medicare to pay for osteoporosis treatment when someone does not actually have osteoporosis. It's still low bone density.
Yeah, but that's why we've been introducing the concept of BMD T-score adjusted, because the BMD T-score adjusted by gender, by ethnicity, pretty much you have something, and now you can sneak the adjustment for the microstructure, and at the end it's still BMD T-score. It's just adjusted by another parameter that can be related to the microstructure, and at the end, if you are below minus 2.5, you're then in an osteoporotic-like category. If you are in osteopenic zone, then you'll go for prophylaxis or something like that. That will be something different. So we recharacterize the patient in a different zone because you adjust for the microstructure.
Perfect. Thank you.
Sure.
Just regarding, I would say that the majority of the our computer system does both on every patient. It's just whether it goes in the report or not, that's the issue. But I would say that the majority of people that we get that are not severe osteopenia or osteoporotic have low trabecular scores. It's just a community practice, a large regional practice in southwest Wisconsin. And the question is, do you find that there's a certain predetermination based on patient history or age that affects the trabecular score in separately from the bone mineral density?
Well, yeah. Well, actually, at the age, you have an age-related decline for both density and TBS. Okay, with a slight difference in the sense that you have enough set of time, between the density lower faster, and the TBS will go also lower faster, but maybe after a couple of years after the density, so slight offset at menopause. So these have been demonstrated in a nice GCEM paper by an American group from a SWAN study, as far as I remember, something like that. So you still have a decline that could be slightly correlated, partially decorrelated, especially if you have a secondary cause of osteoporosis. Then if you have secondary cause of osteoporosis, then you can have a divergence between the bone loss related to density or related to the structure, and that will depend very much if it's a patient, for example, in patient with diabetes. If you have a type 2 diabetic, the density tends to be normal. With the TBS, you tend to have a lower structure of the bone in diabetic patient if the HbA1c level, for example, is not being controlled. So that will be the case in pre-diabetic patient or poorly controlled patients. Then in that case, or you have like a diabetic resistant treatment, something like that, then in that case you will have a divergence between the density and the structure. The same with patient in rheumatology with ankylosing spondyloarthritis, for example, or we call that a bamboo spine. Then obviously the density goes up again because of the artifact, whereas the TBS is still going down. So you have several diseases that can create a disparity between the bone loss in terms of density and the structure.
And also, maybe we don't know all the medication issues or corticosteroid insulin issues that are at play.
Actually, the cortisone is a very important one. There's quite a lot of study now demonstrating that the cortisone will impact the microstructure more than the density itself. So you will creating an acceleration of the bone loss in terms of microstructure in GIO patient as compared to the density, even though the density will be reduced, but even more reduced in GIO patient, for example, because of cortisone. That's a good point. Thank you.
I just had a question that you may have answered earlier about justifying the medical necessity of a trabecular bone score added onto a DEXA to facilitate reimbursement.
Okay, well, the medical necessity, and maybe you can add on that if you want to. Osteoporosis is defined from the early days, we know that, is defined by low bone mass and deterioration of microarchitecture. So you have the two pillars. Unfortunately, in the early 90s, we didn't have access to microstructure, except by bone biopsy at the iliac crest or whatever, but it's pretty invasive. So we didn't have access to microstructure information where we know from the beginning that the microstructure was important in the definition. That's why we have more than 50% of major orthopedic fractures that occurred in a non-osteoporotic zone have been demonstrated by many studies. The fact to add a microstructure information from the axial skeletal side, for example, will fulfill the WHO or NIH definition of osteoporosis. That means just by that, you will have a better bone status estimation that will take into account both aspects of the bone quality and the bone density. So by a medical meaning it is, so it was incomplete before. As you know, it's like you can stand on one leg if you want, you can stand for a while, but it'd be better estimation if you have two legs, which is the density and the quality of the bone. So the necessity, just the improvement of the overall accuracy of the diagnostic for the patient and not missing one patient out of two because you only have partial information.
Okay, so the reliability of reimbursement is high.
Yeah, it's high. Somebody has those numbers. You know, what percentage of the claims are? Well, we don't know the denominator because we don't. But yeah, from our anecdotal experience with people that use this, it's largely. And if you're having trouble, then we have lots of people on the team that can help navigate the issues with why you're not getting reimbursed.
Okay.
Actually, for those, some numbers that we had at one point is for those who submit to Medicare and that properly, it was close to 95% of the people, close to 100% that been reimbursed. Now, having said that, not everybody been submitted claim. So as a number of TBS users in the United States, a small number been doing it. Some other are not aware of it or they don't know how to do it for some reason. But actually, based on 1 year follow-up, like close to 100%, and the little that were rejected, mostly by coding errors, then that can be resubmitted later on. Well, in that case, thank you very much for your attention.